Jay, tell us a little bit about how we approach kind of the classic Philadelphia chromosome positive or BCR-ABL positive ALL with induction therapy and factors to take into account.
Sure. So I think I wouldn't say there's one standard approach for these patients. Actually, you can actually say that about the adult ALL patients too. There's no single kind of induction there. Unlike the pediatric, there's a very set regimen for this, defined by the presenting risk factors. Philadelphia chromosome positive ALLs, I think there are a couple of different approaches that one can take. I think the approach is TKI, we got tyrosine kinase inhibitor, whether it's imatinib, dasatinib, or ponatinib for some of these patients, could be the first-line therapy kind of as a backbone. Induction therapy, there are now a good number of data using this TKI plus steroid, either prednisone or dexamethasone in combination for 90-day induction time. These again tend to be older patients, so who are less likely to tolerate intense kind of multi-agent chemotherapy, so they could be kind of the high level of, could be potentially induction mortality. So minimizing exposure to myelosuppressive induction chemotherapy is one way to really significantly reduce the induction complications and mortality for those patients. If you use that approach and then with a steroid plus TKI at the end of induction again, depending on the regimen, about usually roughly about 90 days or so, you do need some type of a consolidation therapy, and that may depend on the fitness of some of the patients. So I think typically commonly for us, if somebody's treated like that in the consolidation for some of these patients could involve TKI plus chemotherapy, such as hyper-CVAD or mini CVD or some abbreviated version of this multi-agent chemotherapy, or the TKI plus blinatumomab, if they're MRD positive, that could be another approach that could be taken as well. I think there are now increasing data from the Italian studies and other studies as well, using dasatinib and blinatumomab as the kind of frontline therapy, the ALBA study and such as, and those are showing very good results when blinatumomab in combination with TKI using induction and consolidation, some of the patients with less toxicity than traditional chemotherapy. There's the other approach. There's one approach of using, again, the TKI plus steroid. The other approach will be going for younger, fit patients with a Philadelphia chromosome the positive. For those patients getting either dasatinib or ponatinib with hyper-CVAD combination. So I do see that there's another kind of common regimen that people have used, and we have used ourselves as well. So that those typical hyper-CVAD kind of backbone of 8 cycles, and again, TKI they're being added. And there are a little bit more toxicity associated with it, certainly for older patients, but again, for younger fit patients, I think that could be a kind of good option. So either of those approach, I think, is very reasonable to take, again, depending on the fitness of the patients and then the comfort level of the physician treating those. But I think the regimen, there's no randomized trial to compare the one approach will be better. I think the toxicity-wise, it is less with the kind of less intensive approach. And then following that, there's still kind of the remaining question is, should we be doing allotransplant for these patients, so especially when they achieve a good MRD negative or molecular remission with undetectable BCR-ABL transcript. We used to be transplanting a lot more patients with Ph positive ALL, but now with these better agents, such as TKI, and perhaps with the blinatumomab now, that if they achieve a very early and a good, very deep response, are these patients that should be transplanting or just continued with this type of consolidation maintenance therapy? There are high-risk features I think that we're beginning to learn for those patients who are not meeting those landmarks, kind of similar to persistently MRD positive at the end of the induction or certainly after consolidation. Those are proven to be high risk, and for those patients, we are thinking about allotransplant for sure. But again, for the kind of good responding patients, that I think that remains to be answered.
We're actually going to be initiating a intergroup, cooperative group clinical trial next year, randomizing patients to TKI plus blinatumomab versus TKI plus hyper-CVAD. So kind of get at the answer that you're trying to get at the answer that we're mentioning there. I think the big question is whether to transplant those patients or not. And I think you've moved away from transplanting Philadelphia positive ALL patients if they have a good response to initial therapy, right?
That's right. The data suggests that most patients will do quite well with chemo and TKI alone. That being said, there's still about a 30% relapse rate amongst those patients. However, they're highly salvageable. And therefore, I almost feel like the best risk stratifier to identify those who need transplant is actually relapse. I think we've saved a lot of kids from an unnecessary transplant, especially given that they seem to be exquisitely salvageable, and you can get them to transplant, and therefore, I think that's maybe the better way to identify who needs a transplant.